Spring of 1918 marked the beginning of one of the deadliest pandemics in human history. Across the world, an invisible enemy began to emerge, initially unnoticed, yet destined to claim millions of lives. The first signs of the illness were observed in the military camps of the United States, where young, healthy soldiers began to fall ill with unusual severity. At first, physicians believed it to be a typical seasonal influenza, but the disease quickly demonstrated features that were unprecedented: rapid progression, extreme fatigue, high fever, and a deadly affinity for young adults. This strain of influenza, later identified as H1N1, would ultimately devastate societies across continents. The first documented major outbreak occurred at Camp Funston, Fort Riley, Kansas, in March 1918. Within days, over 1,000 soldiers were incapacitated. Dr. Loring Minor, a physician who monitored the outbreak, wrote to the Journal of the American Medical Association, expressing early concern. This influenza is unusually severe and spreads rapidly among healthy young men. Morbidity is high, and deaths have occurred within hours. This is no ordinary influenza. Medical officers noted that symptoms progressed unusually fast. Fevers often spiked to 104, 106 degrees, 40, 41 degrees Celsius. Patients developed severe headaches, sore throats, and extreme fatigue. Many exhibited hemorrhagic symptoms and cyanosis, blue, discoloration caused by insufficient oxygen, which foreshadowed the high mortality to come. The conditions of the First World War accelerated the spread of the virus. Soldiers crowded into barracks, trenches, and transport ships were subjected to exhaustion, malnutrition, and stress, all of which weakened their immune systems. This provided the virus an ideal environment to mutate and propagate. As soldiers traveled to ports and overseas, the influenza crossed oceans and continents. By the spring of 1918, cities including New York, Boston, and Philadelphia reported unusual spikes in illness. Hospitals, many already strained by wartime injuries, struggled to cope with the influx. Beds were insufficient. Families were forced to care for the sick at home, often becoming victims themselves. Eyewitness accounts reveal the terror and confusion of the early outbreak. Nurses reported wards filled with moaning patients, some of whom died in mere hours after the onset of symptoms. Dr. Minor and other physicians struggled to differentiate this disease from typical influenza. Mortality among healthy adults, unusual for influenza, signaled that this pandemic would be exceptional. In letters to colleagues, physicians documented scenes of despair. Strong young men collapse before our eyes, and there is little we can do to save them. Families are terrified, and panic spreads faster than the illness itself. The unique virulence of the virus was due in part to what modern science identifies as a cytokine storm, an overreaction of the immune system that causes internal bleeding, acute pneumonia, and organ failure. Young, healthy adults were particularly susceptible, while some elderly individuals survived due to pre-existing immunity to earlier flu strains. This paradox contributed to the shock and horror, as the virus seemed to prey on those society considered strongest. Internationally, the influenza spread rapidly. Troop movements facilitated transmission to Europe, where France, Germany, and the United Kingdom reported early outbreaks among military units. Civilian populations followed as soldiers returned home, carrying the virus to towns and cities that had previously been untouched. By summer 1918, medical officers in multiple countries noted alarming increases in hospitalizations and deaths. In some cases, the disease appeared to appear simultaneously in distant locations, baffling scientists and prompting early epidemiological studies. Hospitals and medical systems were unprepared for the scale of the outbreak. With limited understanding of virology, Physicians had few tools beyond isolation, bed rest, and supportive care. Antibiotics, which would later help treat secondary bacterial infections, were not yet available. Public health measures such as quarantines, school closures, and bans on public gatherings were implemented, but often too late. Cities struggled to enforce these regulations amid panic and misinformation. Eyewitness reports from affected cities provide a chilling portrait. In Boston, nurses described wards overcrowded with patients, with fevered bodies laid in rows, sometimes 3 to a bed. Families improvised hospitals in their homes, lining hallways with cots for the ill. Newspapers published daily death counts, creating an atmosphere of terror. Some towns reported corpses left in homes because there were no means for burial, highlighting the societal breakdown caused by the pandemic. The virus's rapid spread demonstrated the vulnerability of modern, interconnected societies. Railways, shipping routes, and troop movements facilitated its movement, making containment nearly impossible. Even isolated rural communities eventually succumbed. Some remote areas in the American Midwest reported multiple fatalities within days of the first symptoms, overwhelming local medical facilities. Rural doctors documented the sudden collapse of entire families, with survivors left to bury their loved ones under dire conditions. By mid-1918, the Spanish flu had already infected millions. Governments and public health officials struggled to quantify the scope, with official numbers lagging behind reality. In many regions, mortality rates among young adults reached unprecedented levels. Cities implemented emergency measures, often improvising hospitals, issuing face mask mandates, and restricting movement. Yet the virus adapted, spread, and mutated with relentless efficiency. The social and psychological impact was profound. Entire families were wiped out, children orphaned, and communities destabilized. Survivors recounted feelings of isolation, fear, and helplessness. One Boston resident wrote, "I dared not step outside. Each cough, each breath might bring death. I watched friends and neighbors fall, powerless to intervene. The city felt like a ghost town, haunted by the living and the dead alike." The silent arrival of the Spanish flu foreshadowed the catastrophe to come. By the summer of 1918, the pandemic had spread globally, setting the stage for the second, deadlier wave that would devastate populations and overwhelm hospitals worldwide. This chapter of history illustrates the immense vulnerability of humanity to viral outbreaks and the fragility of societal structures in the face of invisible threats. The disease was not only a medical challenge, but also a profound human and social catastrophe, leaving a mark that would resonate for decades. By combining contemporary medical records, diaries, newspaper reports, and letters, historians reconstruct a world gripped by fear, uncertainty, and the relentless march of a virus that spared neither young nor old, rich nor poor. The lessons of the silent arrival remain stark. Preparedness, scientific understanding, and rapid public health response are essential to confronting pandemics that may emerge again in the modern world. By late summer 1918, the world was beginning to understand that the influenza outbreak was far more dangerous than initially believed. The first wave, though alarming, had been moderate in severity. Yet, as the heat of summer gave way to autumn, a second, far deadlier wave emerged, surpassing all expectations in both speed and lethality. This wave did not discriminate. Cities, towns, rural villages, and military installations alike were engulfed in a tide of illness and death that would challenge the limits of human endurance and societal infrastructure. In the United States, urban centers became epicenters of catastrophe. Philadelphia, a city of over 1.7 million, allowed the Liberty Loan Parade to proceed in September 1918, despite warnings from public health officials. Within days, the city was inundated with thousands of new cases. Hospitals were overwhelmed, morgues reached capacity, and temporary facilities were hastily erected in public squares. Nurses described wards filled with patients lying shoulder to shoulder, many of whom died within hours despite the best efforts of medical staff. Dr. Charles A. Heffernan wrote, "We are powerless against the tide. Strong young adults, previously healthy, collapse before our eyes. Death is swift and merciless." Across Europe, the situation mirrored the devastation in the United States. Soldiers returning from the front lines of World War I carried the virus into civilian populations, spreading it rapidly across France, Britain, Germany, and Italy. Military hospitals reported unprecedented mortality, with soldiers succumbing to the illness in large numbers. Civilian populations, already weakened by wartime shortages, were struck just as severely. Local authorities struggled to enforce quarantines and public gatherings were banned, yet these measures were often insufficient against a virus moving at an unstoppable pace. In India, the Spanish flu proved catastrophic. Beginning in the monsoon months of 1918, the virus spread across dense population centers and remote villages alike. It is estimated that 12 to 17 million people died in India alone, making it one of the deadliest single-country impacts of the pandemic. Eyewitness accounts describe villages abandoned, with bodies left in homes for days due to the lack of burial capacity. Survivors recall the harrowing task of tending to the sick, while witnessing neighbors and relatives succumb rapidly to the virus. The pandemic's pathology was uniquely lethal. The influenza strain triggered a cytokine storm in otherwise healthy individuals, causing the immune system to attack the body itself. Hemorrhagic pneumonia developed rapidly, often within hours of the first fever. Cyanosis, the bluish tint of skin due to lack of oxygen, was a common symptom, and death could follow in mere days. Unlike ordinary influenza, which typically killed the very young and elderly, the Spanish flu disproportionately affected adults aged 20 to 40. Medical officers and nurses were confronted daily with death among those they expected to survive. Transportation, networks and military mobilization facilitated rapid global transmission. Ships, trains and troop movements served as conduits for infection. In Asia, Southeast Asia, Africa, and the Pacific Islands, the virus spread within weeks, often overwhelming communities with minimal medical infrastructure. In Japan, ports recorded sudden influxes of patients, and colonial administrations struggled to maintain public order and care for the sick. In Australia and New Zealand, ports and cities faced similar challenges, leading to the establishment of quarantines and temporary hospitals. The social and economic consequences were staggering. Factories and businesses closed as workers fell ill or died. Rail and shipping networks were disrupted. Public fear paralyzed daily life. Schools, churches, and theaters were shuttered. In cities like Boston, New York, and Chicago, newspapers carried daily death tolls, creating a climate of terror. Families improvised care facilities at home, often succumbing alongside their sick loved ones due to lack of medical resources. The psychological toll was profound. Communities reported mass grief, anxiety, and panic. Children were orphaned by the thousands. Survivors struggled with the trauma of witnessing repeated loss. Eyewitness testimony paints a vivid picture of despair. A nurse in St. Louis described, "We worked from dawn until midnight, yet patients continued to fall, one after another. Bodies lined the halls, and still the sick arrived. It seemed as if the world itself had turned against us." In rural, India, reports describe villages depopulated, with survivors unable to bury the dead fast enough, leaving bodies in homes or along paths, creating scenes of unthinkable horror. These accounts illustrate the extreme human suffering and the collapse of social norms under the weight of the pandemic. Cities implemented various public health measures with mixed results. St. Louis enforced early closures, mask mandates, and quarantines which significantly reduced mortality. Philadelphia, in contrast, delayed intervention, resulting in one of the deadliest urban outbreaks of the pandemic. These contrasting experiences highlighted the critical importance of timely, coordinated public health responses, even when scientific understanding of the virus was incomplete. By October 1918, the virus had reached nearly every continent. Mortality. Estimates suggest that the second wave alone claimed tens of millions of lives, exceeding the death toll of the first wave and outpacing fatalities from World War I. The second wave left deep scars, bereaved families, disrupted communities, and a society grappling with fear of the invisible killer. Newspapers, diaries, and letters from this period record the unprecedented scale of suffering, the suddenness of death, and the pervasive sense of helplessness. Medical professionals struggled to understand the disease. With no vaccine and no antibiotics for secondary infections, they relied on isolation, bed rest, and symptomatic care. Nurses and doctors often became victims themselves. Supplies were scarce, hospitals overcrowded, and traditional medicine proved largely ineffective. The virus exploited these vulnerabilities, highlighting both the limitations of early 20th century medicine and the deadly potential of global pandemics. The second wave of the Spanish flu demonstrates the combined effects of a virulent pathogen and an interconnected, war-torn world. It underscored the fragility of human society in the face of microscopic threats and revealed the catastrophic potential of global epidemics in the absence of coordinated public health measures. Historians estimate that the global death toll from the second wave reached 5,100 million people, a staggering figure that reshaped demographics, social structures, and medical science. By the end of 1918, the deadly wave had passed, leaving a traumatized world behind. Communities mourned unprecedented losses. Governments re-evaluated public health policies, and scientists began the first serious studies into influenza virology and epidemiology. The lessons learned would influence responses to future pandemics, including influenza outbreaks in the 20th and 21st centuries. Yet for those who lived through it, the second wave of the Spanish flu was a nightmare of unrelenting death, fear, and societal collapse. One of the most harrowing events in modern human history. As 1919 began, the world hoped the worst of the Spanish flu had passed. Yet a third wave emerged, less virulent than the autumn 1918 peak, but still deadly. This wave, often overlooked in historical accounts, caused significant additional mortality and highlighted the persistent danger of a virus that had already demonstrated its global reach. Unlike the second wave, which struck rapidly and catastrophically, the third wave lingered longer in rural areas, small towns, and less densely populated regions, slowly claiming lives over months. In the United States, the third wave struck primarily in early 1919. Cities that had enforced earlier quarantines found temporary relief, but were not immune. Smaller towns, where medical infrastructure was minimal, were particularly vulnerable. Public health records indicate that the disease resurfaced in waves, sometimes in cycles of weeks. In Minnesota, for instance, counties that had experienced moderate mortality during the second wave saw renewed outbreaks, with hospitals again reaching capacity. Physicians noted that symptoms were often milder initially, but complications, especially pneumonia, still led to high fatality rates. Europe experienced similar patterns. In Britain, France, Germany, and Spain, the third wave stretched from January to May 1919. Hospitals were not as overwhelmed as in 1918, but the repeated strain exacerbated societal fatigue. Soldiers returning from war zones introduced the virus to new civilian populations, and trade routes continued to facilitate transmission. Mortality among young adults remained high, though the proportion of elderly deaths increased compared to the second wave. Historical records indicate that governments struggled to balance post-war recovery with renewed public health crises. One particularly tragic aspect of the third wave was its impact on children. With schools reopening after closures in 1918, children were exposed to the virus, and mortality among children under 5 surged in several regions. In the United States, local newspapers reported that orphanages were overwhelmed with children whose parents had succumbed to the disease in the previous waves. In India, the third wave compounded the devastation of 1918, particularly in rural areas where healthcare access remained severely limited. Entire villages reported multiple deaths among families, leaving surviving members in desperate circumstances. The medical understanding of the third wave was slowly improving. By 1919, epidemiologists had begun to track transmission patterns and recognize the importance of isolation and hygiene measures. The role of masks, though inconsistently enforced, gained prominence, and cities attempted to implement more structured quarantines. Newspapers advised citizens on hand-washing, avoiding crowds, and disinfecting homes. Yet, despite growing awareness, the virus continued to exploit gaps in societal preparedness. Eyewitness accounts from the period reveal both the horror and resilience of those affected. A nurse in Chicago wrote, "We thought the worst had passed, but the third wave arrived quietly, taking the weakest and the young alike. Families who survived last year's deaths now face more grief. Each day brings new challenges, and hope feels fragile." In rural India, letters from missionaries and colonial officials described villages emptied by successive waves, with survivors forced to organize improvised burials, often using mass graves to contain infection. These accounts demonstrate the persistent psychological and social toll of repeated outbreaks. Economically, the third wave delayed post-war recovery. Factories and farms, already strained by labor shortages and previous illness, experienced renewed absenteeism. Food production and transportation networks were disrupted, exacerbating shortages and inflation. Governments attempted relief measures, but resources were limited, and the scale of the pandemic overwhelmed even the most organized response. Social unrest, though less widespread than during the war, was reported in areas where mortality and economic strain intersected. Internationally, the third wave emphasized the global nature of the pandemic. Shipping routes and trade networks, essential for economic recovery after the war, facilitated continued virus transmission. In Japan and China, the third wave emerged in early 1919, leading to renewed mortality spikes in port cities and surrounding regions. In Europe, epidemics were documented in rural France, Italy, and the Balkans, often following troop movements or seasonal migration patterns. The interconnectedness of the world had accelerated the pandemic, leaving few regions untouched. The third wave also illuminated the long-term consequences of the Spanish flu beyond immediate mortality. Survivors frequently suffered lasting health effects, including chronic respiratory problems, heart complications, and prolonged fatigue. In some communities, psychological trauma was widespread, particularly among children who had lost parents or witnessed repeated deaths. Public health systems, strained for years, began to implement reforms based on lessons learned from the pandemic, including better record-keeping, more systematic quarantine procedures, and early research into vaccines and viral biology. By mid-1919, the Spanish flu began to recede, leaving a world irrevocably changed. Historians estimate that the total death toll worldwide ranged between 50 and 100 million, with multiple waves contributing to the staggering loss. Societies were left to mourn enormous losses, rebuild social structures, and contend with a generation affected by illness and bereavement. Public health practices, medical research, and global awareness of pandemics would all be shaped by these experiences, influencing responses to future outbreaks, such as the Asian flu of 1957 and the H1N1 pandemic of 2009. The third wave's legacy was also cultural. Literature, newspapers, and diaries from the period reflect the trauma endured by survivors. Communities memorialized the dead in mass graves, monuments, and local ceremonies. Families recounted stories of resilience, adaptation, and grief, forming collective memory that would endure for decades. The Spanish flu, particularly its third wave, thus became both a medical and social watershed, highlighting vulnerabilities in health infrastructure, societal resilience, and human understanding of viral disease. In conclusion, the third wave of the Spanish flu underscores the persistent threat of infectious disease, the social and psychological toll of repeated epidemics, and the global impact of a pandemic in a connected world. While less dramatic than the second wave in sheer speed, its extended duration, mortality, and long-term consequences cemented the Spanish flu as one of the most catastrophic public health crises in modern history. Survivors carried both physical and emotional scars, communities struggled to rebuild, and the lessons learned would shape public health for generations. The Spanish flu did more than claim tens of millions of lives. It reshaped the world. By 1920, societies across continents were grappling with the profound effects of a pandemic that had swept through both urban and rural areas, leaving no corner untouched. The global impact extended far beyond immediate mortality, influencing medical science, public health policy, economic structures, and social consciousness. Economically, the pandemic caused widespread disruption. Factories, farms, and businesses struggled as workers fell ill or died, reducing productivity and straining supply chains. In the United States, industrial output dropped as absenteeism surged. Railways and shipping networks, essential for post-war recovery, faced repeated interruptions. In India, the already fragile colonial economy was destabilized, with agricultural production falling sharply during peak waves of infection. The loss of labor, coupled with the death of entire family units, led to long-term social and economic consequences, particularly in rural communities where families relied on collective labor for survival. The social toll was staggering. Urban populations experienced overcrowded hospitals, temporary morgues, and quarantines, while rural communities faced isolation and minimal medical care. In Europe, particularly in war-torn areas of France and Germany, populations were already weakened by famine and stress, amplifying the pandemic's lethality. Families were decimated, leaving children orphaned and communities struggling to rebuild. Schools and churches, cornerstones of societal stability, remained closed for months, further impacting social cohesion. Diaries, letters, and newspaper accounts from the time depict a society engulfed in grief and fear, with people living under the constant shadow of death. Medical science underwent significant transformation as a result of the pandemic. Prior to 1918, influenza viruses were not well understood. Physicians relied primarily on symptomatic treatment, such as bed rest, hydration, and rudimentary supportive care. The Spanish flu exposed the limitations of contemporary medicine, prompting new research into viral pathogens, the development of vaccines, and improved epidemiological methods. Hospitals began implementing better infection control, isolation, protocols, and patient tracking systems. The lessons learned during the pandemic laid the groundwork for modern public health, including the establishment of national health agencies and international cooperation in disease monitoring. Globally, the pandemic highlighted the vulnerability of interconnected societies. The movement of troops during World War I had facilitated rapid transmission, demonstrating how global travel could accelerate the spread of disease. This insight influenced later responses to epidemics, including influenza outbreaks in the mid-20th century. Countries began to recognize the importance of early intervention, public health infrastructure, and coordinated international efforts to monitor and contain infectious diseases. Psychologically, the pandemic left lasting scars. Survivors frequently reported grief, trauma, and anxiety. Communities had to navigate the collective mourning of tens of millions, adapting social practices to accommodate loss. In India, letters from missionaries describe entire villages depopulated, with survivors recounting months of hardship as they struggled to bury the dead and rebuild social networks. In urban centers like New York, Philadelphia, and London, citizens coped with crowded hospitals, daily death counts in newspapers, and the fear of invisible infection lurking in every public space. The pandemic also influenced demographics and population growth. High mortality among young adults altered family structures, leaving many children without parents and impacting birth rates in affected regions. Economic and social recovery was uneven. Some cities rebounded quickly, while rural and war-torn areas suffered prolonged hardship. Public health reforms gradually emerged, including improved sanitation, better hospital design, and the development of protocols for future pandemics. International cooperation began to take shape as a direct consequence of the Spanish flu. Governments and scientific communities shared data, observations, and research findings to understand the virus and prevent future outbreaks. This collaboration marked a turning point in global health, laying the foundation for organizations such as the World Health Organization decades later. Epidemiology, virology, and public health policy were profoundly shaped by the lessons of 1918 to 1920, influencing responses to later pandemics, including the Asian flu of 1957, the Hong Kong flu of 1968, and the H1N1 outbreak of 2009. Cultural responses to the pandemic were also notable. Literature, memoirs, and oral histories from the period reflect the trauma, fear, and resilience of affected communities. Newspapers, often sensationalist in tone, documented daily death tolls and provided guidance on prevention, shaping public perception of disease and government responsibility. In art and literature, the pandemic appeared as a recurring motif, representing both societal vulnerability and human perseverance. By the end of 1920, the immediate threat of the Spanish flu had subsided, but its effects lingered. Survivors carried physical scars. Long-term respiratory and cardiac complications were common, as well as psychological trauma. Economies gradually recovered, yet demographic shifts and labor shortages had lasting impacts. Public health systems incorporated the lessons learned, establishing surveillance systems, hygiene standards, and emergency protocols that would save millions of lives in future outbreaks. In retrospect, the Spanish flu pandemic was not merely a medical event. It was a catalyst for profound global transformation. Societies learned the importance of preparedness, the need for coordinated response, and the human cost of neglecting public health. The virus revealed the fragility of modern civilization when faced with microscopic threats, and it reshaped medicine, economics, and society in ways that endure to this day. The global impact and medical transformation following the Spanish flu underscore a fundamental truth. Pandemics are not isolated events, but forces that ripple across societies, economies, and cultures. The lessons of 1918 to 1920 remain essential for understanding both the vulnerabilities and resilience of human civilization in the face of infectious disease. By 1920, the Spanish flu had largely receded, leaving in its wake a world forever changed. Tens of millions of people had perished, but those who survived carried the memory, trauma, and lessons of the pandemic into the future. Survivors' experiences reveal not only the immediate horrors of the disease, but also the long-term impact on human societies, medicine, and culture. In urban centers across the United States, survivors returned to cities that had been emptied by illness. Streets were silent during quarantine. Hospitals were filled with corpses during the peak, and neighborhoods mourned families wiped out by successive waves. In letters preserved from 1919, citizens described the eerie aftermath. Our block is quiet. Houses stand empty, friends are gone. We live in a city of shadows. Survivors often faced the dual challenge of mourning lost loved ones while rebuilding their own lives amid lingering fear of contagion. Rural communities experienced similar, yet uniquely devastating consequences. In India, entire villages were depopulated. Families who had survived the initial waves faced repeated outbreaks in the third wave, often without medical support. Missionaries and colonial officials documented scenes of isolation, improvisation, and resilience. Children became caretakers for parents or siblings, neighbors relied on collective survival strategies, and communities improvised burial procedures to prevent further spread. Diaries recount the haunting sight of streets lined with the sick and dying, and the psychological toll on survivors was immense. The physical effects of the virus lingered for months, and in some cases, years. Survivors frequently suffered chronic respiratory complications, cardiac problems, and severe fatigue. Autopsies and medical studies conducted in the years following the pandemic documented damage to the lungs and other organs, particularly in those who had survived severe cases of pneumonia. In addition, secondary bacterial infections claimed additional lives even after the initial waves had passed. Medical professionals emphasized that survival did not necessarily mean full recovery, and many individuals bore lifelong consequences from their ordeal. Psychologically, the trauma was widespread. The sudden, relentless deaths among healthy adults, combined with the fear of infection, left survivors with lingering anxiety, grief, and depression. Families who lost multiple members, particularly young adults, were often forced to reorganize social structures and economic roles. Children orphaned by the pandemic faced unique challenges, including lack of guardianship, disrupted education, and emotional trauma. Social historians note that the pandemic left communities grieving collectively, with memorials, monuments, and rituals emerging to honor the deceased and process the loss. The pandemic also reshaped medical practice and public health. The unprecedented scale of the Spanish flu exposed vulnerabilities in hospitals, sanitation, and medical knowledge. Epidemiologists and physicians learned critical lessons about viral transmission, quarantine enforcement, and community health. Hospitals began implementing more systematic infection control procedures, isolation wards, and tracking of contagious patients. Public health infrastructure expanded in response to the lessons of the pandemic, laying the groundwork for modern responses to infectious disease. The necessity of scientific research into viruses became clear, prompting early work that would eventually lead to vaccines and antiviral treatments. Education systems adapted as well. Schools, shuttered during outbreaks, reopened with improved Hygiene measures. Teachers and administrators developed protocols to manage future epidemics, including isolation of symptomatic students and temporary closures when necessary. Communities recognized the importance of communication and education in preventing disease spread, leading to more organized public health campaigns in the following decades. The economic consequences for survivors were profound. Many households lost primary earners, resulting in poverty, displacement, and dependence on extended family networks or charitable institutions. Industries that had been strained by worker illness during the pandemic faced long-term labor shortages, prompting changes in labor practices and social safety nets. Governments began to understand the need for coordinated response to public health crises, which influenced policy decisions throughout the 20th century. Globally, the Spanish flu served as a harsh reminder of the interconnectedness of human populations. Troop movements, shipping, and trade had facilitated rapid viral spread, underscoring vulnerabilities in a world becoming increasingly mobile. International collaboration in disease monitoring and public health response gained prominence. Scientific communities began sharing data across borders, laying the foundation for modern epidemiology and organizations such as the World Health Organization. Cultural and societal responses to the pandemic also shaped the collective memory. Literature, newspapers, and oral histories documented both the horror and resilience of communities. Novels, memoirs, and personal letters preserved first-hand accounts of suffering, loss, and survival. Communities erected memorials for the deceased, from mass graves in India and Europe to local monuments in American cities, ensuring that the memory of the pandemic endured. Public commemorations served both as mourning rituals and as warnings for future generations. The legacy of the Spanish flu extended into the scientific and medical communities. Research conducted in its aftermath improved understanding of viral disease, respiratory infections, and epidemiology. Vaccines for influenza became a scientific priority, and public health systems were strengthened to detect and respond to future epidemics. The pandemic also revealed the importance of communication, hygiene, and early intervention in limiting the impact of infectious disease. Perhaps most importantly, the survivors themselves embodied resilience and adaptation. Individuals who endured multiple waves of infection demonstrated remarkable physical and psychological fortitude. Communities rebuilt social structures, re-established economies, and recovered culturally. These human stories of perseverance, chronicled in diaries, letters, and oral traditions, provide a vivid reminder that even amidst unprecedented loss, societies can endure and adapt. The Spanish flu pandemic, particularly through its multiple waves and staggering mortality, remains one of the most catastrophic health crises in recorded history. Its impact on survivors encompassed physical illness, psychological trauma, economic hardship, and social disruption. Yet it also sparked transformations in medicine, public health, and international cooperation, shaping the modern world's ability to respond to infectious disease. In reflecting on the legacy, historians emphasize the dual nature of the pandemic's aftermath: immense loss paired with transformative learning. Survivors carried forward lessons about hygiene, isolation, and the importance of scientific research. Communities adapted to the social consequences, rebuilding economies, schools, and healthcare systems. Globally, the pandemic left an enduring imprint on how societies perceive and respond to health crises, influencing policy, preparedness, and the collective understanding of disease. Ultimately, the Spanish flu is remembered not only for its death toll, but for the resilience of the human spirit. Survivors' experiences illuminate the fragility of life and the extraordinary capacity of societies to endure, adapt, and learn. Their stories, preserved in archives, letters, and oral history, continue to inform public health, inspire scientific research, and remind humanity of both the dangers of pandemics and the potential for recovery and growth. The narrative of the Spanish flu concludes not merely with mortality statistics, but with the enduring lessons for future generations. It is a story of suffering, adaptation, and transformation, demonstrating that even in the face of a global catastrophe, the human capacity for survival, innovation, and resilience can shape the course of history.